So good morning, everyone, again. For the session of the Max Planck Research Group, Practices of Validation in the Biomedical Sciences, part one of the Health Beyond Medicine Day. Who are we in order of appearance? This is Lara Koik, the group leader, Alfred Freeborn, myself, Hanna Wolicek, Michele Lucchetti, Ariane Hannemeyer, Sam de Couron, and Simon Broche. And we have the pleasure to have Rebecca Jackson chairing us during Q&A. We will present a collaborative perspective on the research group's topic, Practices of Validation. We aim to showcase how a cross-disciplinary approach to the history of such practices that represents the output of group work rather than individual research projects. And for the record, we already gave this presentation last year in July at the biennial meeting of the International Society for the History, Philosophy and Social Studies of Biology, but back then with a second session attached. But without further ado, I'd now like to ask Lara to start our presentation. And you will have the opportunity to ask questions and put your comments in the second half of the session.
Thank you very much, Hanna. Okay, so it's my great pleasure also to welcome all of you here. I will now give a brief introduction into the starting point of this research group. Validity and validation play a huge role in the modern sciences of health. We will then present selected results of our research that illustrate the breadth of the topic, but also carve out common threads. Here we will concentrate on 3 of these threads, each of which will be discussed by 2 scholars. First, Alfie and Hanna show why diagnostic validity is not only a history of global standardization. Then, Michele and Ariane look at internal methodological and external institutional drivers of validating pain measurement. Finally, Sam and Simon examine the dark side of validity and approach evaluative categories through their misleading uses. The conclusion connects the threads to the overall research framework of the group. You can follow the plan of the presentation on your handout. We will also post that in the chat for the virtual attendance. And we will begin now with the first row in the table and introduce you to the group's research framework on historicizing validity. So let us start with some difficult cases, because issues of validation become particularly obvious in controversies. For instance, how do we know whether a vaccine is safe and effective? How do we know whether an animal bioassay is suitable for predicting that a chemical can cause cancer? Or how do we know whether a psychological test measures what it purports to measure? And here I just want to do a brief shout out to Sasha Bex from Katz, the artist who's also now an artist in residence and postdoc in the group, for the wonderful pictures of historical intelligence tests. So these questions beg, of course, further ones. Who asked these questions? When and for what purposes? Indeed, validation is always addressed with reference to purposes. For instance, the quality assurance of commercial pharmaceuticals or the legal use of chemicals. So we can say that validation comes with high stakes. Validity itself is assessed with respect to its adequacy for a given purpose. Indeed, this relational character of validity has already been articulated in some of its first conceptualizations in the human and health sciences. Educational psychologist Truman Lee Kelly described this in 1927 as follows. The purposes for which schoolmasters have used tests have been too intimately connected with the will of their pupils to permit the validity of a test to go unchallenged. The problem of validity is that of whether a test really measures what it purports to measure. Since the 1950s, validity is represented as correctly hitting the target mark. It is often opposed to reliability, which is depicting as always hitting the same area but not necessarily the right one. This is a very abstract idea of validity that is applied to an idealized target. However, historically, the definition of target constructs has been contentious. To come back to our examples, what is immunity? What is intelligence? Validity seems to involve the acceptance of a set of operations as an adequate definition of whatever is to be measured, or at least this is the case for a specific understanding of validity. Indeed, this claim has been made in 1955 with respect to criterion-oriented validity. This is a quote from one of the most influential papers on validity. Clinical psychologist Lee Kronbach and psychometrician Paul Mehl introduced a more elaborate validity terminology. Their new concept of construct validity allowed to ask, how informative are the applied tests about the not directly observable abstract construct, such as intelligence? This points to the methods of measurement, which are tied to practices of validation and which are often tightly bound to the definition of the target constructs. Obviously, there is a risk of circularity here, and this has been one of the central concerns of measurement theory. Moreover, normative choices get baked into methods, as we will see in the following. So in this research group, we are putting particular emphasis on the multidirectional relations, which allows us to analyze validation, matters, sciences, and health as historical variables, and to historicize validity as a relational property. So how do we do this? Let us now exemplify. We begin with the validity of diagnosis. So Alfred and Hannah, the floor is yours.
Okay, thank you very much, Lara, and it's a pleasure to be here and to be repeating this presentation. So we're asking, do we have global standards in biomedicine? And as well as asking, do we have these standards, we're asking, why do we have these standards? And our argument is that these two questions can never be separated. So, as Lara outlined in her introduction, validation and validity always make sense in relation to a specific purpose. In this thread, we examine how validity is articulated and debated with regards to diagnosis. We're going to focus on two perspectives. First, the case of schizophrenia, a psychiatric disorder which is diagnosed by a set of psychological and behavioral criteria. And secondly, the case of toxoplasmosis, an infectious disease which can be diagnosed through serological testing, in other words, blood tests. Now, while both of these disorders are regularly diagnosed around the world, and there are international diagnostic standards for both, in practice there is substantial regional variation in diagnostic practices. Now, this is not surprising, given both the complexity of these two disorders and the different purposes for which a diagnosis can be used. We argue that to understand how international diagnostic standards relate to these regional and local practices, we have to understand how diagnostic standards are established at specific scales, which link certain practical purposes to certain evaluative categories. The World Health Organization has organized studies seeking to validate diagnostic tests, which can serve as global standards, but the types of validity relevant to global standards are not always the most important at regional and local scales. So I'll start with schizophrenia. This is my topic. So there are no laboratory tests for schizophrenia. It's diagnosed by a mental health expert based on an interview with the patient and often their family. However, there is a standard clinical picture in use by clinicians around the world today. You can see here the symptoms list from the World Health Organization website. It highlights persistent delusions, hallucinations, disorganized thinking, and negative symptoms. So schizophrenia is a type of psychosis, and it's differentiated from other psychotic disorders in the practice of differential diagnostics. And this is difficult in practice. So there's been disagreement about the borders of the schizophrenia disorder since the concept was created at the beginning of the 20th century. And in order to overcome this problem, the WHO developed a program to create a standardized diagnostic interview, and this focused on developing a semi-standardized tool which enabled the reliable recording of mental symptoms. As well as developing this tool, they developed a computer program which could generate a reliable diagnosis of schizophrenia based on these specific symptoms. And so the 4 studies that you can see here, beginning with the International Pilot Study in the 60s and ending with the International Study of Schizophrenia in the 1990s, were one of the largest and longest continuous studies of patients with schizophrenia ever conducted. And these studies were on the one hand about validating new methods for diagnosing schizophrenia, and at the same time validating a particular diagnostic concept of schizophrenia. So trying to settle the question or provide consensus over the question of what schizophrenia is. So these studies were widely interpreted as validating the cross-cultural existence of schizophrenia. They also helped establish a standard international diagnostic concept for schizophrenia and suggested that recovery rates for these patients were better in developing countries as opposed to developed countries. Since the 1990s, the WHO, with funding from the World Bank, has produced estimates on the burden of disease of schizophrenia from all countries. This is the map that you can see here. And despite extreme variations in data quality, there's now a standard unit for measuring the disability caused by schizophrenia. However, these standardized methods, which the WHO developed, required substantial training to use, and they've never been implemented in everyday practice. They answered the question of whether schizophrenia could be diagnosed globally in the affirmative, but this has often obscured, rather than resolved the problem of understanding local differences in illness patterns. Used for managing patients in local contexts, the utility of the WHO standard has been questioned. Medical anthropologists have argued that the diagnosis lacks conceptual validity. In other words, it has no referent in the sick person's cultural background. So since 2008, psychiatrists in the global north have argued for the scaling up of mental health services to the global south in what is known as the Movement for Global Mental Health. Now, this argues that the ICD, the International Classification of Disease, be used globally in order to make visible the mental health burden in countries from the global south. The psychiatrist Derek Summerfield, a strong critic of this movement, has been a visiting lecturer in psychiatry at the National School of Medicine in Bulawayo, Zimbabwe. This is the country's second medical school. And for several years, he argues that young doctors there felt pressured to deploy these WHO diagnostic standards in order to appear scientific, although these often fail to capture the particularities of local patient experiences and symptoms. So to conclude, we do have global diagnostic standards for schizophrenia, but we have to ask why we have them and what purposes they were designed for. We have to ask which sickness phenomena they make visible and which they conceal. In other words, the global is not the same as the universal, but is one useful scale of validity among many. And with that, I will hand over to my colleague, Hannah.
As opposed to schizophrenia, human toxoplasmosis has an identifiable biological cause, the parasite Toxoplasma gondii, and can be diagnosed through biomarkers. The parasite was first described in 1909 based on its morphology, as you can see in the left upper picture. The full life cycle, which is complex, was only established around 1970, identifying cat feces and contamination by it as important sources of human infection, as well as consumption of raw or undercooked meat. If a primary infection happens during pregnancy, the fetus can be infected as well, with potentially severe consequences. And this has been known since the late 1930s. In the global north, toxoplasmosis is mostly asymptomatic in immunocompetent adults. But virulence varies drastically, with more virulent strains in Central and South America as well as in Africa. The diagnosis has been mostly limited to serology. From 1948 onwards, the diagnostic gold standard has been the Sabin-Feldman dye test. The WHO became involved with toxoplasmosis in 1957. And since the late 1970s, commercial tests have been marketed, raising new questions of validation and standardization. On the level of individual patients, the incentives for standardization are reliable and reproducible results. Moreover, comparability of diagnostic results across labs is critical for implementing treatment or prevention strategies. On a different scale, public health interventions like screening programs require a firm legal basis with standardized procedures and guidelines. But also, epidemiological data generated with valid methods are needed as a basis for decision-making on the population scale. However, standardizing toxoplasmosis diagnostics has been confronted with severe challenges. First, there are no vaccines and eradication is impossible, both contradicting strong incentives for concerted actions by the WHO. Second, the disease burden is considered relatively low as compared to other congenital infections like rubella. Third, the serological results are not predictive of the pathology in an individual case. And last, the disease burden can vary drastically from region to region. Despite these challenges, standardization on different scales serves as the basis for various practices of validation in this case, like evaluation, calibration, comparison, or correlation, aiming at reproducibility, robustness, accuracy, and comparability. But the WHO was only really effective on the level of calibration. But it also facilitated comparison by organizing multi-center studies. If we take a look on the current situation, we can attest a failure in using the products of global standardization in resonance with local specialties in resource settings. As a consequence, there are still no robust global data available on toxoplasmosis. But moreover, we see a transfer of evidence-based guidelines from settings with low disease burden, like the United Kingdom, to non-comparable settings. And to a certain extent, the exchange of standards across healthcare systems failed. So what did the WHO, considered a major actor in standardizing biomedicine, do? An international standard serum was produced in 1967 and an international unit defined to be used for reporting test results. But not even the WHO itself ever adopted reporting in this way. The serum, however, was increasingly demanded internationally, shown by an increasing number of laboratories ordering the reference serum plotted in the black line on this graph. If we look on the application side, West Germany was faster than the WHO. Already in 1965, a legal requirement was established to report congenital toxoplasmosis, and that required the national standardization of testing, including official guidelines and the national reference serum. The results were not reported using international units, but the national standard was compared with the WHO standard when evaluations were finally published. This is in stark contrast to France, which also standardized tests early on. France adopted the WHO standard, but in contrast to Germany, French scientists used these international units since 1968, which made it very hard to compare the results published by scientists from other countries. And although French scientists campaigned for the global use of international units, they were not successful with that. Comparing scales of standardization reveals that on the global level, the WHO was successful only to a limited extent regarding toxoplasmosis serology. It coordinated multi-center studies to validate different tests. It made recommendations for the storage of blood sera. It provided an international standard serum as a positive control for calibration and international units for its activity. On the other hand, on the national and regional scale, large prevalence studies were conducted since the 1950s. National reference laboratories were gradually established and official guidelines published. In 1974, the first nationwide screening program for pregnant women was introduced in Austria, only followed by France and the German Democratic Republic in the next decade. If we look on the granularity of standards expressing their complexity, it is very low on a global scale and gets more elaborated the smaller the unit of organization is, with the local level exhibiting full-scale implementation of guidelines for diagnosis, interpretation, and intervention. Regarding the executive power of the involved official entities, this is at least partially caused by a lack of executive power on the global scale, and the highest regulatory power on a legal scale on the national or federal level. To conclude, let's come back to our initial question. Do we, and if yes, why do we have global standards in biomedical diagnostics? Our two quite different cases together reveal important aspects of the tension between the strive for global standardization and its practical implementation. First, the WHO can stimulate standardization, especially through coordinated efforts regarding concrete practices of validation. But second, it cannot implement the use of standardized practices. Political, financial, and authoritative influences and resources limit this capability. Third, the standards produced might not be reflective of regional demands in diagnosis and treatment. Such factors might outrule global standardization attempts. This includes cultural aspects, resources, disease burden, and an evidence-based medicine dominated by a few countries from the global north. Our studies reveal that post-World War II vision of a global biomedicine has been indeed contradicted by regional practices of applying global standards, if they exist at all. Sometimes positions of the WHO are even contradicted by the scientific consensus, also indicating that the work of the WHO is only slowly progressing if certain incentives for urgency are not met. And with that, I hand over to the next thread with Michele and Ariane.
Thanks, Hannah. So, in the second part of our session, Ariane and I will put our respective case studies on sensation and pain measurement in relation to a specific tension. This is the tension between internal methodological movers and external movers for resorting to validation practices and to validity as a methodological concept. My case study focuses on the origins of psychophysics in the mid-19th century. It is not self-evident how the birth of a relatively obscure subdiscipline of psychology relates to questions of validity in the 20th century, especially with respect to biomedical sciences. And histories of validity usually trace the origins of this notion in the early 1920s debates surrounding a pressing issue. How do we make sure that our procedures measure what they're intended to measure? What I'm focusing on here is on the fact that the founder of psychophysics, Gustav Theodor Fechner, even if he did not talk about validity, does have a place in this history. So we are in Leipzig. It's an October afternoon in 1843. Fechner is a medical doctor who turned professor of physics. He's walking in his garden and he's blindfolded. He's been sick on and off for years with partial blindness, insomnia, weight loss, and flight of ideas. He did a lot of experiments on after images, the perceptual impressions that remain on the retina after looking at intense light sources. And of course, these experiments contributed to his eye issues. However, he's starting to feel a little better. He takes off the bandages in his garden and he sees flowers in his garden, which seem to be talking to him. He starts believing that flowers and all beings might have a soul. Now we jump forward a few years. It's 1850. Fechner is in bed and has another sudden realization. He's been working on his philosophical view, according to which the physical and the mental are only two sides, two manifestations of one and the same reality. He realizes that the relationship between the physical and the mental must have a precise mathematical form. It must follow logarithmic proportions. Fechner dedicated then the following 10 years until 1860 to find scientific evidence for this relationship, which in turn could ground the possibility of measuring the mental in terms of the physical. And to refer to the study of this functional relationship between the mental and the physical, he coined the term psychophysics. Psychophysical methods had, however, been systematically used before Fechner's time in the work on touch that was carried out by Ernst Heinrich Weber, who was also a friend of Fechner. What Weber did was to use comparisons between stimuli to identify thresholds of experience. That is, to identify the minimum stimulus that was required to perceive a sensation. Fechner searched for knowledge of the nervous system to directly investigate the causal processes giving rise to sensation, but he couldn't find any. So his innovation was then to use Weber's methods, which he called methods of outer psychophysics, which relate behavioral response data to physical stimuli, to gain access to the inner psychophysical processes, whatever goes on neurophysiologically internally to the body, what he did not have access to. The possibility of this methodological jump to use sensations, external sensations, to investigate the internal goings-on was justified by Fechner's assumption that we all share a common human physiology. So for the purposes of establishing the correlation between the mental and the physical, individual differences in the physiological makeup of test subjects are irrelevant. In addition, this assumption that we all share a common physiology justified the possibility to use himself as one of few or even the only test subject for his experiments. Epistemologically speaking, this assumption replaced the process of standardizing a measurement instrument, in this case the human sensory apparatus. So to establish psychophysics as a fully quantitative discipline, however, Fechner had to construct a mapping between the intensity of sensory stimuli, which was the only physical proxy that he had to access what he was interested in, that is, experience, and, of course, the latter, experience, which he operationalized as intensity of sensation. So this mapping was necessary to ground the possibility of quantifying the mental in terms of the physical. However, there was a circularity issue looming in the background. How could he identify B, the functional relationship between the intensity of the stimulus and the intensity of sensation, without already presupposing some quantitative understanding of what is intensity of sensation, that is, what is a unit of intensity of sensation, if these units are equal and if they can be summated. In the absence of independent support for his definition of a unit of sensation, he set out to construct his measurement scale through a bootstrapping process that was based on transforming Weber's empirical results into a definition of a psychological unit. And then this led to his formula that related intensity of experience as a logarithmic function of the intensity of the stimulus. So there's no time to give the details about his whole process of constructing these measurement standards, but what is important is that the later history of psychophysics established that Fechner's units of sensation, which we called the just noticeable differences, cannot be considered as uniformly equal as he wished. And his measurement formula had only limited applicability, only for a limited range of sensations, of sense apparatuses. However, Fechner's way out of the circularity issue made it possible to treat the psychophysical data mathematically for the first time. And this over time enabled the empirical investigation of the quantitative relationships among units. So in over time, this led to an improvement in the measurement standards themselves. In this sense, we can regard Fechner's temporary solution to the circularity, even if not fully successful, whatever this means, as providing sufficiently valid measurements to start off a successful process of improvement of epistemic iteration. And in this context, the assumption of a common human physiology has a special epistemic place because it provided an anchor to keep the circularity problem I mentioned before stable and for psychophysical measurement to be improved over time. So to conclude, I come back to our internal and external tension. So, of course, Fechner's background as a doctor and a physicist, as well as the transition of the German intellectual landscape from the Naturphilosophie to quantitative science that was occurring at the time, certainly guided him to search for validation of his psychophysical view in scientific facts. Hence, his strive for exact psychophysical quantification. However, he tackled the validity issues of his psychophysical project as internal issues to be sorted for successful quantification, thus by scientific standards. Finally, Fechner unleashed a real revolution in the quantification of the body-mind relationship. So he opened a new perspective at the intersection of psychology, medicine, and technology that was very influential and still is today. And in this case, I highlighted how his strategy to cope with the problem of measurement circularity was motivated by anti-literam considerations about validity and resorted to practices of validation that anticipated 20th century approaches to calibration, experimental control, and statistical analysis in psychology. While his drive to achieve an exact quantification of experience was driven by a very influential model of measurement at the time, the Euclidean model, his motivation for resorting to validity reasoning were driven by issues that were intrinsic to constructing quantitative models of qualitative states. And with this, I conclude, and I leave the floor to Ariane.
So I just want to ask you all to take a moment to look at this scale of measuring pain. And you could choose any one of the scales here, but just choose one. And you don't have to tell anyone, but just decide for yourself how much pain you're in at this current moment. Probably what you are most familiar with is the happy face scale, or these scales that are associated with a kind of 1 to 10 or 0 to 10. And I'm going to tell you a little bit about how that became institutionalized according to certain external movers or external reasons. So jumping off nicely from the work of Fechner, as Michele has explained to us in 1860s, and the development of this barely noticeable difference, Fechner's law of increased stimulus, increased response gets taken up in the 30s and 40s through the experiments of Hardy, Wolff, and Goodall. So whereas Fechner had a scale of 21, their scale, Hardy, Wolff, and Goodall, was comprised of a scale of 10.5. Hopefully you're already starting to see a connection here. Their method involved what they considered a very humane setup. Basically, there was a radiant heat lamp that would shine at either your forehead or onto one of your hands. And what you would do is describe out of a certain number what intensity of pain you were experiencing, and they would correlate that with the wattage of the lamp. So what's significant here is the way that they change that it's not just about the stimulus, is that it's actually the reaction, what's reported by the person who's experiencing this particular increase in wattage. So there's a move here from an experimental atmosphere looking at kind of psychological laws of perception to that of the reaction. So they're trying to standardize a pain scale for everyone in this particular experiment. And later, this way of measuring the perception of pain given a response, such as in illness, will serve as the kind of dosage structure to manage certain types of drugs for the treatment of pain. In the 40s, they also used these experiments to measure the response while administering analgesics. So they take the same kind of setup and they start administering painkillers to see if that affects some kind of difference. And it does. They found that their participants in their experiments could tolerate more pain if they administered analgesics, and then they could tolerate more wattage over time. So despite this kind of interest in the research from both the kind of physiological communities and clinical communities to try to see how pain treatments may actually work, these experiments were actually quite difficult to reproduce, as there was a lot of variation between participants as the experiments were repeated in different contexts over time. So following this debate about the various ways to establish an objective measurement in research, a new way of translating these kinds of subjective to kind of objective measures emerges in the clinical discourse at this time. So one of the critiques of the Hardy, Wolf, and Goodall experiments had to do with its applicability. Variation in these disease states was brought up as a potential obstacle to standardizing a measurement of pain. So in the 50s, Sloan Kettering and Harvard led a study which was performed by Howden Rogers, and these patients then became something quite novel at the time. They became their own control group. So instead of trying to standardize across measures, they tried to use the very reporting of each patient from time 1 to time 2, the administration of painkillers, as the standard baseline in order to be able to assess whether there was an improvement in the intensity or the reporting of pain. So they would then ask patients how they felt on this scale of 1 to 10 after each hour of the administration of painkillers. So the results would report on a kind of summary of these scores, which each of the drugs tested, and 2 elements then become inserted into the clinic from this experimental mode that I want to kind of draw our attention to. So this style, first, of allowing the patient's experience and the reaction to their pain through the management of drugs becomes the kind of standard in clinical trials. And this verbal scale out of 10 gets reattached to this kind of 10-point Dole scale, as they refer to it. So this improvement. So why does this happen? I think there's a few things that are really important to draw our attention to about why it is that they want to be able to standardize certain elements in the clinical sphere. And that has to do with the rise of clinical epidemiology and the emerging kind of standardization of a hierarchy of evidence that's going on. So the results of kind of randomized controlled trials that measure the effectiveness of pain treatments, for example, or any kind of therapy, is used to translate that knowledge of effectiveness to the bedside. And that's the kind of goal of clinical epidemiology at this time. And there are a number of different things. I just draw your attention to 2, which is that various resources are created for the clinic in order to be able to translate that, such as the Oxford database, as well as journals like the Journal of Clinical Epidemiology that is meant to translate these things. So why is it that this links up with these pain scales in a particular kind of way? And how is it that that happens through the process of institutionalization? And I want to draw your attention to the profession here. So an international association for the study of pain is created over the 60s and 70s, which aims to provide clinical assessment tools, but for the effective measurement of pain treatments. So in a report authored by the International Association for the Study of Pain Research Committee, one of their founding committees, in fact, they recommend 3 particular types of states. So for one, they say they recommend further studies on quantifiable measures, so like pain scales, for assessing pain magnitude and pain relief, following that therapeutic intervention, just as Rogers and Howe did. This includes research in the area of psychometrics, social science, psychopharmacology, with the goal of attaining more quantifiable methods for assessing subjective sensations, perceptions, and reactions associated with pain disorder. Another alignment with these kinds of objectives of clinical epidemiology, right, translating that kind of knowledge to the bedside, and the need to include that evidence of clinical effectiveness in decision-making is also observed in the institutionalization of pain medical education, which is presided over as well by this international society. At the time, Dr. Melzik, who's author of gate theory, which is at a very prominent theory about pain at the time, he stated in one of the council meeting minutes over concerns over the fragmentation between pain research and its application in clinical practice. It was suggested that drug development should be aided by this professional society over the next few years by meetings on methodology and also the results of clinical trials. So additionally, education in pain medicine was also undergoing a reform. There were a number of ad hoc international subcommittees on medical school courses and curricula, which generated proposed ways that undergraduates should be learning about how to assess pain in the clinic and to be able to bring the knowledge from these big trials to the bedside. So within it, they were teaching new students this definition of clinical pain, which was created by the society, as well as basic sciences and clinical application. So modules included the measurement and quantification of pain. The curriculum documents were approved and then published in their international journal Pain. And this kind of aligns with that broader discursive relation here of clinical epidemiology in the way that they wanted to make medical decisions standardizable on the basis of particular results from the controlled trials and teaching physicians how to do that, especially when it came to pain management. Again, we see the overarching role of the World Health Organization in the 1990s as the international society establishes a relationship with WHO. And in October of 1990, they begin establishing guidance for how it is to connect that pain scale, that clinical measurement with various drugs and how to use that scale of measurement in research. Now, where I think this is important is where the rubber meets the road, which is how it is that validation and its institutionalization meets up with certain regulatory bodies. So on the slide here, I have the documents that were submitted by Purdue Pharmaceuticals in order to have OxyContin approved for clinical use. And here, what you can see here is that the baseline is based on particular patients reporting their pain in relationship to placebo, but also from time 1 to time 2, right? You can see the baseline, what was their pain, 2.3. Overall, how does that change over time? And so it's this very standardized measure of using the patient themselves as their own, kind of baseline, as their own standard by which to assess the effectiveness of drugs that actually comes to play a significant role in regulatory bodies as well, which I'd be happy to talk more about in the Q&A. So to return to our tension between these internal and external reasons for this push towards quantifying the qualitative experiences in pain measurement, we can see that there are issues with standardizing measures of pain across populations where there's insufficient knowledge about the mechanisms of pain between this kind of notion of sensation and reaction. So one of the ways that they sidestep this issue or deal with this is how individuals, then the patients, come to play a key role in developing ways to deal with this problem of measurements of pain. And it's through these discursive and institutional relations that become the movers of this story. Like the rise of clinical epidemiology played a significant role, as well as professional organizations themselves. So I think this is where I get to turn it over to Sam and our next theme for the presentations. Thank you.
Thank you very much. I'm very pleased to be here. So now we're going to talk about the dark side of evaluative categories such as validity or reliability. They do indeed help us in producing knowledge, but they also have what we call a blinding effect. That is, they might prevent us from using tools, for example, scientific methods, in the most generative way. This is why Simon and I have been wondering how the use of evaluative categories leads or misleads us into over-hastily accepting or rejecting a scientific method. We'll show this with 2 case studies. Simon shows us with the standardized quality assessment that users, in this case, believe their tool doesn't work. It's my case. Doesn't work, but it's because they are thinking in terms of reliability, which isn't the right category to use. And in my case, which I'm going to develop now, in the animal welfare sciences, users believe their tool does work and they're really proud about it. But in fact, I contend it's because they are not using the right evaluative category. So I studied the U4, the University's Federation for Animal Welfare, which is like the mother institution of animal welfare sciences, founded in 1926. And as you can see on this leaflet, their aim was to link knowledge to legislation. The idea was to make valid knowledge, to start from validity in order to make social change and protect the animals. The underlying belief behind that is that in order to protect the animals, you need more validity. And this is because from the late 19th century, there had been movements for the defense of the animals. And the U4 members said these movements were too sentimental. And being too sentimental, they were too focused on the political debate, too radical, and then they never attained validity. They never could convince the governments and then couldn't lead to legislation. This is why the U4 motto was, we have to tackle animal welfare problems with a maximum of sympathy, meaning we are actually leading towards the protection of the animals. Like this is our main and our end aim, but with a minimum of sentimentality. And so how did they do that? They created animal welfare sciences as a research program, meaning they organized as a federation of universities from 1926 and getting bigger and bigger during the 1930s. They received funding, public and private, and they organized a growing number of symposia, national and international. This led to major publications such as the 1959 book by Russell and Birch, which is still in use today for ethical research protocols, and which I will use this later. It proposed the 3 R's principle, which said we have to reduce the numbers of the animals we're using, to replace the animals by other models, and to refine our use of animals. And these results, like the research program building, led to legislation. Indeed, from the 1947, so the very first handbook published by the UFA, regulations were implemented in the lab in an informal way, and this led later to the 1968 Act on the protection of animals in the lab. So it all looks like a success story, and the U4 looks like it's a better tool than the previous animal defense societies, such as the one you see here. And why is it so? The U4 members say it's because all these previous movements are too sentimental, soft, and womanish, as they said, which is they are not valid. They are not talking about something valid. And why are we so much more efficient in convincing the governments to make laws? It's because we are using valid concepts. But I contend there is a dark side to this. The UFO indeed participated in replacing, but it's not replacing the animals with other models for science, but rather they replaced previous movements for the animals and then silenced a very important political debate. So they shut down a whole question about the use of animals. Second, they reduced the concept of welfare itself, and it's lost its meaning during the first 3 decades of the UFO career by practices of validation. I'll show that later. And then they refined the use of the animals themselves, and by refining, I mean optimizing them. So first, on the sociological level, they replaced, because contrary to what the UFO handbooks most generally say, the UFO did not invent the concept of animal welfare. The expression animal welfare was used by the NCAW 1923, so 3 years before the UFO was founded, and the NCAW was a radical anti-speciesist group, which was explicitly against the use of animals in the lab. And so, in fact, what happened is that the UFO appropriated the concept of welfare in order to replace such groups, radical groups, because, in fact, they were not only not so efficient in protecting the animals, but mainly because they were threatening science. And this is visible because in the UFO, most UFO members were also members of the British Science Guild and the Research Defense Society, which were groups founded at the beginning of the 20th century and radically engaged into what they called the defense of the scientific method, and very explicitly against the anti-vivisection movement, which was against animal use in the lab. And they also had revolving doors with the industry and the government. So that was very interesting. And it was a good strategy. Secondly, on the conceptual level, validation practices like the effort to make welfare or the welfare movement a scientific movement, the validation practices led to the reduction of the concept of animal welfare. So the UFOs work on the lab practices, which in the beginning aimed at reducing the numbers of animals we used, in fact led to the reduction of the concept of animal welfare to like a statistical process of calculating and optimizing the use of the animals and especially their suffering compared to the production the knowledge we could produce by using them. Third, we find how did they manage to not reduce the numbers of animals used? It's mainly because the UFO had a huge impact on three things. First, they participated in standardizing the practices in the lab by their handbooks, etc., but also like the architecture and the logistics in the lab. Second, they had this huge campaign linked with the government, which aimed at centralizing and regulating the relationships between the producers, so that the breeders, and the users, the lab workers. And last but not least, they had a huge impact on the constitution of what we now call the lab animal as a reliable data. And this was like cornerstone of their work. Like we need to have reliable data at the basis of our valid concept of welfare. And this is why we have to standardize the animals in a genetic and pathogenic way. So that's what happened. So if we look from the UFO's eyes and we use and we think about their history in terms of validity, it looks like a success story, and it did indeed achieve its aim. But if we think that the right evaluative, like if we think it's the very aim of animal welfare sciences is welfare itself, like we are here, like doing science in order to promote the welfare, then I contend, and many other scientists contend, that the tool doesn't work. Thank you very much. And now I leave the floor to Simon.
Thank you, Sam. So in my research project, I'm looking at standardized quality assessment of clinical trials. And as I will show, the blinding effect of evaluative categories can also go the other way around. So when conducting a meta-analysis, only clinical trials that are adequately designed and executed should be considered as evidence. Hence, whether a given trial makes it into meta-analysis depends on the quality of the methods used to produce it. Trials in which serious quality concerns have been identified are usually excluded from meta-analysis, such as trial C in the example on this slide. Therefore, quality assessment essentially serves as a gatekeeper for meta-analysis. Since the 1960s, numerous approaches to standardizing quality assessment have emerged, and they always come in the form of a questionnaire about various features of the trial whose quality is being assessed, such as whether the allocation sequence was random, whether participants were aware of the intervention they received, or whether the outcome measures were appropriate. However, it quickly turned out that assessing the way a certain trial was conducted is not as straightforward and unequivocal as it may seem. In fact, quality assessment is inter alia unreliable. If we let two scientists assess the same trial with the same questionnaire, they usually come to different results. For this reason, some medical researchers have put into doubt the usefulness of standardized quality assessment, such as Greenland, who calls it the most insidious form of subjective masquerading as objectivity in meta-analysis that merges objective information with arbitrary judgments. And until today, standardized quality assessment is very unreliable, as is evident, for example, by Hartley and colleagues' evaluation of the Cochrane risk of bias tool, which is the at present presumably most widely used quality assessment tool for randomized controlled trials. So if it was the aim of standardization to make quality assessment inter alia reliable, then its history would be a history of failure. Standardized quality assessment is and always has been inter alia unreliable. But when taking a closer look at its history, it turns out that it is actually hard to find cases in which those who develop standardizations consider reliability as their primary goal. In fact, most and especially early toolmakers did not consider reliability as an evaluative category that their tools should meet. Early standardizations were first and foremost developed for pedagogical reasons. Main and Daniel, for example, state that the purpose is to provide a guide for the physician who is untrained in such matters. It is not directed to the skilled investigator who has to find for himself those criteria which he regards necessary for an adequate clinical trial. And also later toolmakers take the need for making subjective judgments and thus the possibility for intersubjective variation for granted. Andrew, for example, explains that some variation was expected as different experience in clinical research among the evaluators and subjective evaluations are obvious factors. Hence, it seems that standardized quality assessment is not only unable to achieve inter alia reliability, but, with a few exceptions, it was also never intended to do so. So while standardizing quality assessment was initially not directed to the skilled investigator, and reliability wasn't something that the toolmaker strived for, it became nonetheless common practice and at some point even mandatory to make use of these quality assessment tools when conducting a meta-analysis. And when used in meta-analysis, the results of quality assessment were usually taken at face value, namely to make a definite decision as to whether or not a given trial should be included into meta-analysis. That a different investigator could have come to a very different quality assessment was not further taken into account anymore. Hence, there seems to be a tension between what toolmakers developed their tools for and what meta-analysts used them for. A tension between theory and practice. At the current stage of my research, I suspect that it was only through the way in which quality assessment tools were used in meta-analytic practices that concerns about reliability were forced upon the standardization of quality assessment. As a consequence, toolmakers tried to increase inter alia reliability, but as we know today, without success. So today, standardized quality assessment is considered valid but unreliable. We know that the aspects of trial design and execution that are used as criteria for quality assessment have an impact on the trial's effect estimates, but we don't manage to make their assessment inter alia reliable. Resulting from the tension between theory and practice, reliability established itself as a category by which all quality assessment tools must be evaluated, but which none of them is able to achieve. But we've also seen that standardizing quality assessment has not always been thought of in terms of reliability. And it has only been taking reliability as the purpose of validation of standardization that the occurrence of subjective differences becomes a problem. I therefore claim that thinking of standardized quality assessment in terms of reliability makes it difficult to see that standardization could also be used differently. It obstructs the view of the potential benefits of subjective differences in quality assessment. This is what I consider an instance of the dark side of evaluative categories. As soon as we overcome reliability as an evaluative category for quality assessment, we can start exploring whether there may be an epistemically fruitful way to accommodate subjective differences in the standardization of quality assessment. That's what I'm currently investigating in my research. Rather than using standardized quality assessment as a tool for increasing reliability, which it fails to do anyway, I suggest to embrace its unreliability and to turn it into a tool for transparency. By uncovering the reasons for subjective differences that would have otherwise remained hidden, it would help us to get closer to the ultimate goal of quality assessment, namely to better identify methodological flaws in clinical trials. So to sum up, we hope to have shown that there is also a dark side to the use of evaluative categories in science. In the case of animal welfare, the notion came into being as a tool for questioning whether animals should be used for scientific experimentation, but in the hands of scientists, it became a category for evaluating how to best use animals for experimentation, thereby obstructing the view of the initial question. And in the case of quality assessment, reliability developed towards an evaluative category that should be strived for, but which cannot possibly be met. Not calling into question the usefulness of evaluating quality assessment in terms of reliability thereby obstructs the view of other ways in which it could be used. It is therefore important to remind ourselves that evaluating scientific practices in terms of certain categories is not carved in stone. We should always ask ourselves, what is a scientific practice good for, and does its evaluation in terms of certain categories help us to get closer to what it's good for? In our two cases, evaluative categories haven't gotten us closer, but rather contributed to losing sight of the actual goal. That's what we call the blinding effect of evaluative categories in science. And I now hand it back to Lara for some concluding remarks.
Yeah, thank you. So let's wrap up. This was the relational research framework that I presented at the beginning of the talk. As you see on the sheet that you have, or on the PDF that you got, we have a variety of theses that derive from the specific projects. But on a meta level, all of the theses exemplify in one way or another the relationship of validity to health, methods, and power. With respect to health, we have explored the relationship between assumptions about health, disease, welfare, and evaluative categories in modernity. Regarding methods, we have traced the inter- and transdisciplinary history of evaluative categories and methods across sites and times. And with respect to power, we have examined the uses of validity talk and validation practices to regulate and legitimate or delegitimate knowledge and action. And with that, I would like to hand over to our great moderator, Becca Jackson, who's also a postdoc in the group, and thank all of our funders and especially you, the audience, for coming here today.
Thank you all for your wonderful presentations. I'm delighted to be moderating today. And thank you all for attending. I'm going to get us started with just a couple of questions of my own, and then we will stop the recording and open the questions up to everyone. So first, I just wanted to comment that I think a strength of this group is a wide array of historical and disciplinary contexts in which you explore validity, from psychiatry, meta-analysis, issues in laboratory sciences, clinical applications, and more. But I want to know individually how you identify as a scholar, as potentially an interdisciplinary scholar yourself. Is there an inner team working within you? And could you describe that relationship as an individual in this group? And we can maybe just answer one at a time. Would you like to start, Laura?
We were told that we should take a breath before we start talking so that the mic has a moment to turn on. Yeah, thank you. Well, I think I always kind of visualize my own work as being at the intersection of history of science and philosophy of medicine. But of course, and I think that has become very evident while listening to the different talks, there are many other intersections to these fields also from other disciplines or taking kind of like other approaches. So I think for me, on the one hand, kind of like working with this framework and then having all of you work with me was at the same time a possibility to really look how far can we go with this kind of merging of history of science and philosophy of medicine, but also really using like the creativity of all of you to see what we could add to the mix, or what we need to make certain features really visible. And so, yes, I do think I have kind of like my own inner team, but I also kind of like externalize that a bit.
Well, I have indeed an inner team because I would characterize myself as a chimera, with a past as a microbiologist, and including a postdoc life, and then turning to the history of science, doing another PhD. And so the way these two work together, the historian of science and the former biologist, is that the biologist is well aware of especially implicit aspects of knowledge, tacit knowledge, practices that might not appear as such, for example, in published scientific papers or in lab books like visual practices. But on the other hand, the historian in me always has to fight the dangers of anachronism there, because it would, of course, be catastrophic to just imply experiences from the 1990s and 2000s to the 1940s. So I would say these two aspects, professional aspects, have a very fruitful interaction with each other, keep each other at bay and interact with each other. But also with regard to group work, which was the standard in biology and is definitely not the standard in the humanities, I very much enjoyed that we are actually able to do something more than our individual projects and help each other, but also use occasions such as this to think in different ways together and to even find out new aspects that we wouldn't have considered when only working on our individual projects.
Thanks. This is the worst question anytime someone asks what my disciplinary background is. I say, well, it depends who I'm talking to. So today, I think what I'll say is I'm very inspired by the kind of Max Horkheimian kind of idea of like critical social studies, right? So bringing together the philosophy and history alongside social studies. And so typically, I guess I consider myself a critical sociologist insofar as trying to historicize key knowledge systems or conceptual development over time and looking at what the conditions of their institutionalization were. What is my inner team, though? I don't know. A bunch of different, whoever I'm engaging with, I think is my inner team, right? Really trying to engage with critical theory, historians, sociologists, anthropologists. But like I said, I think it depends on the day. Yeah.
I absolutely agree with Ariane that it really depends on the day. And today I'm feeling very at peace with the identity question, strangely, because I started out with the group as I would say a strong identity as a philosopher of science with an interest in history. And over time, with the group, this has pushed the boundaries of what I count as a philosopher. And I feel that with this sort of permeable attitude that we share in the group, this identity has expanded and integrated a lot of things that I wouldn't be able to integrate before. I think this has been very important to me, to expand the borders of what counts as a philosopher, integrating what happens around me.
Wonderful. Yeah. I found this whole process actually, although we've performed this before, actually seeing it again, I took so many notes, learning so many new things about, what we've actually been doing. So I think, this question of how we work as a group and our disciplinary identity is an ongoing one. And happy to as Ariane and Michele have said, sort of take a spin of the wheel and pick a new one. But I do, maybe to take a more critical stance, do think about the whole framing of the research project does have a very strong philosophy component. And maybe this is also to do with the disciplinary identity of this institute that we're in now. What are the questions that we ask? And it is incredibly epistemologically focused, and we're looking at the history of methodological concepts. And I think looking forward to how our work will continue, as a historian, as someone who's trained disciplinarily as a historian, it will have to be reframed and repackaged in a way to meet with other historiographical themes that are beyond the philosophy of science and medicine. And so that is a kind of, maybe to, cat amongst the pigeons, suggest that there is a limit as well to balancing these different disciplinary identities within a single research group.
Thank you. So yeah, it's a tough question because it feels like there's a crowd inside. But if I can split them in like three main groups, like the first is, because of my training in philosophy, they are philosophers of science. The second one is historians, and it's actually when I arrived in the group in 2021 that I started having real good access to the archives. I'm falling in love with the archives and the historical method. So now I feel more confident now to saying like I'm a philosopher and historian of science, whereas like even 1 year ago I would just say I'm a philosopher of science trying to do a bit of history. But the third group is, I think, like the leading group now is the critical theory philosopher trying to like have an actual impact in the activist movements and in the political debate in general. So they are like struggling, each pulling the line for the blanket on them. But in the end, I would say, yeah, the captain is the philosopher, like trying to get to some clarity. But the guys who are the strongest are the critical ones. Like, if we have a valid concept but it doesn't change anything, then just don't work on that. I would say that.
Thanks. Yeah, for me, my disciplinary identity doesn't depend on the day, but I think that's a very interesting way of seeing it. So yeah, and I also don't necessarily feel a crowd in me or several identities, but like my background is in philosophy and only in philosophy. And like, however, I still use methods from other fields and especially history. And while like when I started my PhD, I first took it like kind of for granted that like mixing up methods from different fields would necessarily lead to something fruitful. Like the philosopher in me soon started to kind of question why I'm doing all of this rather than sticking to the methods I actually learned and I know. And this then led me to kind of reflect more thoroughly on how like my historical research should inform my philosophical argumentation. And then I actually believe that this kind of monodisciplinary background or identity can have like an epistemically productive function when doing interdisciplinary research, which means like for me now I've kind of an anything goes approach with respect to methods, independently of where it comes from which field, but only if it has kind of passed the critical look of the philosopher in me. Meaning it will only be used if there's a clear gain that can be expected for my philosophical argumentation. So for me, it's really like the identity as a philosopher that helps me to kind of navigate in this interdisciplinary environment in, I hope, a productive way.
Well, thank you. So my next question, actually, a couple of you have touched on this a little bit, but I want to give you an opportunity, anyone who hasn't yet, to talk about how your individual identity has been shaped by being in the research group together, and maybe just if you have some peek into the future of how you might carry what you've learned as a group forward in your individual careers. Maybe just to touch on that a little bit, give us an idea of what's next for you.
Maybe one thing I've definitely learned from this research framework, and I think this conversation with Lara a few years ago, is that by looking at the history of validity, you realize that all research projects remain unfinished. Nothing is finally validated. And it's a good life lesson in a way to get a sense of when you do research, it is for a specific purpose. And you have to remind yourself why you're doing these things in order to then understand when something is finished. And so I feel like that's a kind of a research lesson, but also a sort of life lesson that you can take away with you about really knowing what the pursuit of knowledge is for and thinking about it that way.
My partner works on the philosophical foundations of mathematics and said to me in a phone call the other day, I proved something today. And I just had this moment of thinking to myself, like, wouldn't that be great to feel like I came to some kind of ultimate conclusion? What to bring forward? I mean, I think that what has been really beneficial is working on the more like hermeneutic processes of communication, or listening, in a really deep way, in terms of what to bring forward. Like skills for collaboration have been so foundational in this group in terms of really understanding the other's view from a foundational kind of standpoint, not just like, oh, those are your results, here are my results, and we have this kind of superficial exchange, but rather something that's closer about, how certain assumptions that are either disciplinary or maybe even more practical have informed the very basis upon which we have to kind of come together to have dialogue, right? And I think that has been something that has been truly transformative for me in being a part of this group. Yeah.
Well, as a reflection of today's presentation, but also what we did for the conference last year, I mean, I was well aware of the fact that interdisciplinary work needs extra time and extra attention. But really doing that in a group that is composed, as you see now, with very different from very different identities, really showed that we have to really take the extra time to invest if we want to reach something that is not clear from the beginning. Yeah. So, okay, we want to show that and then you do it, but we wanted to really see what comes out if we think like in pairs, for example, for this presentation. And I think it's really worthwhile to do that, but also to be aware that you have to pay the attention to that someone has to herd the cats, and keep it going, and take responsibility for the group somehow. And temporarily we change these roles, not one person has it all the time. And I think that's also something I learned about this particular group, is that this is possible, which is very good. But this is also based on a high level of trust within the group, I would say.
Thank you. I have a comment that goes in a very different direction. And so like an institute like this one, it's by nature interdisciplinary, and maybe especially in my role kind of as a PhD student, I sometimes wonder whether engaging in too much interdisciplinary research might at the end kind of bear the risk of losing one's disciplinary identity, which in kind of this research environment doesn't seem like a problem, because like everyone is engaged in doing all this like interdisciplinary stuff. But once we get out of this environment and go into a different academic context, I wonder whether it might actually be a burden at the end. And so like this is like a question I sometimes ask myself, and to which I don't have an answer, of course. But I think this could be something also interesting to discuss maybe later with the audience, if anyone has experience in this.
Yeah, I think this idea of like we need a common purpose is important, but I also think the idea of, well, there are different purposes for different people, and there are different like ways how the careers and lives will continue is also important. And I think like for me, maybe one of the most interesting things that happened in the research group is kind of that we had very often discussions about how to find a good balance between like creating a common goal and giving everyone authorship and also kind of like individual context that might be more fit for your purpose, right? And I do think that that's maybe a specific challenge for group work in the humanities, right? That your own authorship needs to be kind of like recognizable, and so there are sometimes tensions, but I think like the way we try to solve that is that there are individual projects, right? And there are individual settings in which you kind of like present these, but then there are also these collective endeavors where we try to bring things together again. But I do think that there's still a lot room for more discussions on a methodological level, how we do that kind of group work in the humanities. And I'm very thankful to see Dora nodding and to learning more about how she's doing it with her group too this afternoon.